Hello, good evening. My name is Ömer Göktekin. I'm chairing the session tonight, session 6 actually, which is Medtronic Complex PCI webinar session. Tonight we will talk about heavily calcified lesions, and the first speaker is a very well-known complex PCI operator, Ahmet Algundi, and he will talk about contemporary approach to heavily calcified lesions in complex PCI. So please, Ahmet, go ahead.
Thank you, Omar. So thank you everyone for joining us. I'm conscious this is Ramadan. It might be a bit too soon after Iftar, but I think this is the last of this is the 6th wave of the series, and we hope you found the previous sessions useful. Let's hope this is a useful session as well. So without further ado, this is essentially focused on heavily calcified lesions, and we'll try to keep the theoretical component to an absolute minimum to give room for a number of excellent case presentations, as a matter of fact, to be presented later in the webinar. So the first thing is, how big is the problem with calcification? We do encounter them a lot. And we also know that this has a direct relationship with age. The older the patients get, the more likely you are to see a degree of calcification regardless of how severe. We also know that there are a number of risk factors associated with coronary calcifications beyond age. So diabetes, dyslipidemia, hypertension, male gender, smoking, and chronic kidney disease, which has a very complex relationship with calcification, are amongst the strongest risk factors. And if you look perhaps at the pattern of calcification with those different risk factors, you can appreciate that the vast majority are associated with intimal calcification, or with a combination of intimal and medial calcification, perhaps apart from very distinct features related to chronic kidney disease. And you've all seen patients who are on dialysis with extensive medial calcification. It's essentially due to a reduced glomerular filtration rate, but with actually minimal or hardly any intimal calcification, mostly on the medial side. So these are different risk factors, although they have different implications on intervention per se, but they're important to keep in mind. Now, the other thing is a complex interplay between calcification and natural history. So we tend to think of calcification as an adverse feature, an adverse anatomic, perhaps physiologic feature, but as a matter of fact, with very continuous sheet-like calcification, they tend to reflect a pattern of stable coronary disease, where patients are more likely to present with stable angina or heart failure rather than an acute coronary event. On the other hand, we now understand that this pattern of spotty or speckled or fragmented calcification is associated with plaque rupture. And if indeed you look at this, this is one of the excellent papers published back in 2018, looking at the different patterns of coronary calcification and the incidence of acute coronary syndromes. You can indeed appreciate that plaque ruptures are more frequently visualized or more frequently seen in patients with moderate rather than severe coronary calcification, in which this sheet-like assortment seems to confer a degree of plaque stability. So we've understood and we've known that calcium is a problem for the past 40 years, and surprisingly, this comes from no less than Andreas Grunzig back in '79, where he quite rightly acknowledged that the current techniques available, or the techniques available back then, which were limited to balloon dilatation, are limited by anatomic features, and calcium was given as the primary culprit here. So what exactly are the technical challenges that we encounter with severe calcification? Crossing the lesion can be a problem, the so-called balloon uncrossable lesions. Failing to predilate lesions adequately is also frequently encountered. Failure to deliver stents, especially if calcification is coupled with tortuosity. And because we resort to aggressive and repeated predilatation, they are prone to create dissections, hematomas, which can lead to loss of side branches, some of which are important. And perhaps the main limitation with calcification is under expansion of stents, which we have come to understand or come to acknowledge as the main reason for stent failure on the long term. So we've seen repeatedly, this is from Gary Mintz's group, and you can see that there's a strong correlation between the completeness of a calcium arc in terms of degrees circumferentially and the stent expansion as such. So the more you get a complete arc around the vessel, the less likely you are able to expand the stent at a given atmospheric pressure. We also see this paper from pooled analysis from two large trials, Horizons AMI and Acuity, and you can see that the presence of calcification with severe calcification here depicted in red is always associated with an increased risk for major adverse cardiovascular events at 1 to 3 years respectively. And all the individual components of the major adverse cardiovascular events are also significantly increased when you compare severe calcification to non or mild calcifications. Now, luckily, we are at an era where the technology has advanced dramatically, and we do have a number of options. So be it ultra high pressure OPN balloons, for instance, scoring balloons, cutting balloons, excimer laser, rotational atherectomy, orbital atherectomy, or shockwave lithoplasty, the latest kid on the block, all constitute different tools that allow us to deal with calcified lesions, albeit they obviously work in different ways. And it is also important to understand the strengths and weaknesses of each to be able to tailor therapy. Now, understanding calcium and dealing with calcium in the cath lab perhaps could not have been done without the evolution of intravascular imaging. So we've been repeatedly stressing the importance of intravascular imaging throughout the series, be it in chronic total occlusions, in complex left main bifurcations, in complex scenarios with acute coronary syndromes. But perhaps calcified lesions are again one of the most important areas where the use of intravascular imaging is fundamental to understanding the pattern and degree of calcification, which will obviously determine the mode of treatment or therapy that you want to proceed with. But also, it can give you an idea about what the result is. So we see on the left-hand side here how calcium appears with intravascular ultrasound, and you can see this a very radio-dense line that goes all the way almost circumferentially, perhaps with this bit between 6 and 7 o'clock. And you can also appreciate that the blooming artifact you get from the lack of a shadow behind the calcium because of the intense ultrasound fragmentation behind the calcium sheet you get with intravascular ultrasound. Now, IVUS is notorious for not giving you information about the depth of the calcification or the thickness of the calcium ridge per se, but one tip that we frequently resort to is seeing this calcium reverberation line. So when you get this calcium reverberation line, that does not happen with areas of dense calcification. So if you look at 3 to 6 o'clock, for instance, there is no reverberation, and this indeed is probably a very thick sheet of calcium, as opposed to what you're getting between 9 and 12 o'clock, where you see the second line deep within the radiolucent side. Now, OCT, on the other hand, while it doesn't give you as much tissue penetration, so in very large left mains, for instance, you might not appreciate the entire depth of the calcium, does give you, when the vessel is not too large, a very good idea about the extent of calcification, and it gives you an important idea as well, an important clue about the depth of calcium and the thickness of the calcium sheet per se. But perhaps one area that is not as frequently utilized with intravascular imaging is not just understanding the pattern of calcium, it is also understanding how that calcium behaves with whatever therapy you used. So if you're using rotational atherectomy or shockwave lithoplasty, and you want to appreciate what effect this treatment had on the vessel, so intravascular ultrasound can give you a very good idea. So in this occasion, you can clearly see the cracks within the calcium sheet seen here. We're moving backwards and forwards within the lesion at 12 o'clock and 1 o'clock with very clear cracks. And you know that this is exactly what you want to achieve. And hence you can sort of confidently move to the next stage in your procedure with putting stents. So how do we, in a contemporary fashion nowadays, think about calcified lesions? So this is a very brief roadmap to calcification and extremely insensitive when it comes to understanding the pattern and degree of calcification as such. So with mild calcification, a balloon pre-dilatation to assess how you're palpating the lesion, as we say, to understand how the balloon behaves, how the vessel conforms to the balloon, and if you're able to achieve
Did we lose him?
Yes, Flavio, I think we lost him. Just wait for a while. I think he will reconnect.
Hello, I'm sorry for that. That's one issue with webinars. I carried on with the presentation and I apparently lost connection. So, Omar, would you stop exactly?
Yes. Ahmed? Oh, you have a... So...
Yes,
okay.
Omar, sorry, I lost the connection.
That's fine, that's fine. You are back now, right? Or still we have difficulty, yes?
Can you resume slideshow? Share your screen.
Ahmed, yes.
Yeah. Yes, here.
Yes, please go ahead.
I had a bit of a connection issue, sorry for that.
That's okay.
So I'm not sure where exactly you lost me. That's one issue with webinars. I carried on without knowing that no one was listening.
Just beginning of this slide, Ahmed.
Yeah.
Okay, brilliant.
Yes.
So,
Yes.
with mild calcification, obviously, balloon pre-dilatation to understand how the vessel behaves to your balloon inflation is probably a very reasonable strategy. If you get good expansion, then proceed with stenting and utilize intravascular imaging to ensure that you achieved good expansion. However, with moderate to severe calcification, the plot thickens to some extent. So when you get severe calcification, or perhaps the easiest part is if you're unable to cross altogether with a balloon. So this is a scenario where rotational atherectomy, and this is what we're familiar with in this part of the world, or orbital atherectomy becomes your go-to solution. And after doing that, you again test with the balloon. If you achieve good expansion, then utilizing intravascular ultrasound and OCT for optimization is the next step. Then if you are still unable to achieve a good balloon expansion after your initial rotational atherectomy or orbital atherectomy run, then you have the options of either utilizing a lithotripsy balloon or upgrading your burr size. So if it were a 1.5 burr, you can upgrade to a 1.75 burr, depending on what the distal reference vessel diameter is. Now, in the presence of moderate calcification, where you can't really make up your mind, this is where intravascular imaging becomes extremely useful. And a number of parameters we look at are the completeness or the continuity of calcium arc, with anything above 180 taking 2 points. A calcium arc of more than 270 is a particularly adverse feature, which almost always points towards the need for a dedicated calcium modification tool. Now, remember, you're not dealing just with a focal point within the vessel. So if you get this arc at a 1 millimeter length is one thing, but if you get a complete arc that extends for a long segment within the vessel, this obviously adds to the complexity and to the resistance you're going to encounter with stent expansion. And if you get a thickness of more than 0.5 millimeters, And we've just sort of understood or shed some light on the differences between OCT and IVUS in that respect, then that's yet another adverse feature. So if you have the majority, and it's not like we really do get a pen and a paper and start counting points, but this is more or less of a broad guidance. The more points you gather, the more likely you're going to require either a rotational atherectomy or a lithotripsy balloon. Depends on where you practice, what you have available, and what you're comfortable and experienced with. And the less the numbered points, the more likely the less invasive or the less demanding techniques such as a high pressure non-compliant balloon or a cutting balloon can work. Now at every and each point, if you fail to achieve good pre-dilatation, that would push you to upgrade your therapy either to a lithotripsy balloon or a bigger burr. And again, to move this towards the more theoretical, more practical side, this is an elderly gentleman, 79 years old. You can appreciate distal left main disease, proximal LED disease, a bit of calcium on with plain angiography. You can appreciate that the proximal circumflex disease, albeit not extending to the ostium. A totally occluded right coronary artery, which is filling retrogradely from septal collaterals. And you can appreciate that the right coronary artery is quite calcified as well. So this is sort of more or less of a classic patient that we are encountering in our practice nowadays with aging individuals and better referral routes. So this was a patient with a syntax score of 42. However, given comorbidities, the heart team decision was PCI. And the plan here was a staged procedure going for the left system first, followed by the right system a week later. We decided to keep it simple in the absence of involvement of the ostium of the circumflex, go for focal circumflex stenting, not extending to the bifurcation, go for LED rotational atherectomy, then left main LED sizing using OCT for optimization. And this was a quick fix for the circumflex with a 4-0 stent. Then you can appreciate, given the moderate pattern of calcification we saw on the coronary angiogram, we decided to go for a pre-dilatation with a non-compliant balloon. That was a 2-0 non-compliant balloon. And you can see that it still has waste. So the immediate next step was rotational atherectomy. And perhaps this is, and again, I'm speaking more and more on a practical level. I understand the limitations of practicing in Egypt and perhaps other countries in the region, but it doesn't really help to sort of escalate balloons, go with a 2-0, then a 2-5, then a 3-0, suffer from a number of ruptured balloons, end up with a significantly dissected vessel, lose a few side branches, then stop and say, this is the time for rotational atherectomy. If you think that you're going to require rotational atherectomy, doing it early on is not only time efficient, is not only safer for the patient, but is also cost effective on both short and long terms. So given the small size of the distal LED, we decided to go with the 1.25 burr initially. Then we did another balloon dilatation. We can still appreciate the waist over here. So we upgraded to a 1.5 burr. And this was and I'm sorry I don't have bigger images, because what you can appreciate with the OCT images is that we've indeed achieved a good fracture in the sheet of calcium at 3 o'clock. Then we went for 2 stents as a matter of fact, a 275 and a 35. Did a number of post dilatations, ended with a pot in the left main, and this was the final result. So I think this was trying to keep things simple without having to do a 2-stent strategy from the outset, spare the ostium of the circumflex, and ensure very good pre-planning or preparation for the lesion before putting in stents. And you can see that the post-PCI OCT really gives very good diameters in the confluence, in the distal confluence or the confluence of the distal left main, and the proximal LED and proximal circumflex vessels. And a week later, Again, that was a bifemoral, or sorry, right femoral and right radial axis. And given that the calcium on angiography was much worse in the right coronary artery compared to the left system, this was a simple antegrade wire escalation using a fielder XT, but we started off with a 1.5 Burr straight away. And this was the final result after putting in a few stents. So the second case is an 83-year-old gentleman, chronic kidney disease, glomerular filtration, chronic kidney disease with moderate impairment, hypertensive, complaining of shortness of breath and chest pain on mild exertion. And he used to have a very active lifestyle up to a few months prior to this current presentation. Echo showed severe aortic stenosis with an EF of 60%. And the reason I'm showing this case is, again, this is a common scenario that we encounter: patients with combined aortic stenosis and significant coronary artery disease, where we don't really know what the proper sequence is. Should we fix the coronaries, especially with such a proximal severe coronary disease? Should we go after the valve initially, then fix the coronaries? This was done like 3 years ago, and at the time, my personal practice was sort of always preferring to go after the coronaries initially. I have to admit I'm hardly dogmatic about it anymore. But again, given that this patient was going to require a rotational atherectomy, perhaps doing it after fixing aortic stenosis might be of added value, because these patients are very intolerant to no reflow or slow flow. So back then anyway, you can see a left main trifurcation, proximal LED and proximal circumflex disease, severely calcified proximal LED, and again, a totally occluded right coronary artery, which we opted to leave alone. And the decision back then was to do a stage procedure, pre-dilatation for the circumflex, where all three vessels, 1.5 Burr down the LAD. Then we decided to keep things simple. You can appreciate that there's a dissection in the ostium of the circumflex after balloon dilatation. We did a classic T-stenting on this occasion, again, opting for simplicity. Did a number of post-dilatations, and this was the result after the kissing import. So we managed to preserve the ramus as well. The plan here was to keep it open without doing any interventions. And a week later, we went for a 29 millimeter Sapien XT back at the time. And that was the result. So the third case is actually a discussion opener. I'm sorry for that. So my take-home message before giving you a couple of slides for the panel to discuss is coronary calcification is common indeed. And angiography has very limited sensitivity to detect both the degree and pattern of calcification, the extent of the calcium arc, length of the calcified segment, depth of calcification, and thickness of calcification are all important features. And intravascular imaging is indeed critical to determine the need for dedicated calcium modifying therapy, help identifying which is the best modality for this particular patient and anatomy, assess the response to treatment, and most importantly, ensure adequate stent expansion or minimal stent area, because we now know that this carries or sort of is the major determinant of stent failure on the long term. Now, this is an 89-year-old lady, and perhaps this is the reason for showing this without showing the result initially, is to take the panel's vote on what would be the best modality for treatment. So this is an 89-year-old lady, crescendo angina over the previous week, culminating to a prolonged attack of chest pain at rest prior to presentation, extensive peripheral vascular disease, and with a troponin positive on this presentation. Right coronary artery was totally occluded, and again, flush from the ostium with hardly any retrograde flow. So perhaps I stop at this stage and ask Flavio, Omar, Hussein, everyone, what would be their, how would they proceed?
Who wants to start? Omar, you moderate, you make the questions.
So sorry. So I was speaking myself. Sorry. Anyway, thank you very much, Ahmet. It was great presentation. Before we start the discussion, I'd like to introduce other panelists here. We have Flavio. We know him, very well. He actually, I like to thank him for these 6 sessions webinar. He had presented great cases and lectures. I am very happy to have him here tonight as well. And we have Hani Ragi here, Maged Ramses and Amr Al-Gundi as panelists, and also we have 2 more speakers, Ahmed Kasaba, who is a very good operator, and another good operator is Hussein Hasmat. He's also will present some cases tonight. So let's speak about this case. This is very calcified case, Ahmed. It's LAD osteal lesion and very calcified. It's very old lady, and he has unfortunately unstable angina, right? So we have to do something about her.
Yeah.
So Filario, let me ask you, what would your approach in this case?
Well, good evening, everybody. First of all, I want to congratulate Ahmed for this perfect, I'd say it's perfect talk on calcified lesions. You know that it's a topic I like very much, but he addressed very clearly all the most important issues from the diagnosis to the treatment. And so I really enjoy it, and I am sure it is very useful for all of us attending tonight. As to the case, I mean, this is an 89-year-old lady, and of course you will treat her just because she presents with unstable angina at rest. Otherwise, I would prefer not to touch her. But from the angio, it's clear that the lesion of the LAD, it's ostial. So you have to think about treatment left main LAD. Never imagine that you will be good at putting the stent on the edge and will be okay. I mean, this is wishful thinking, but this case you need to treat left main LAD. It's very calcified, and it's a very tight lesion. When the calcification is so important and the MLD is so small, my preferred strategy is going straight forward with a small 125 bar. And eventually, as Ahmed said, if the balloon does not open up very well, a 2.5 or 3.0 balloon still having residual risk, upgrade to 1.5, and this will be enough. The good thing is that the ostium of the circ looks clean, but of course, to make sure that you will manage this with a single stent, so a simple procedure, the IVUS will help, because the IVUS will not cross the LAD lesion, but will go to the circ, and you would see a nice clean ostium, so it would be very safe to do the rotation without a wire in the circ, and then putting a protection wire on the circ, but putting your stent left main LAD and doing your case with provisional technique and a final pot on the left main. This is what I would do. Of course, minimizing the contrast media, and this is why IVUS is important, because these old people have impaired kidney function. So you can do this procedure with 1 injection in the beginning and 1 injection in the end. And if you have your IVUS catheter on the table, you will assess dissections, residual stenosis, side branch opening, everything with the IVUS. You do practically a contrast-less procedure, which is very important in these patients.
Okay, Flavio, thank you very much for your comment. I like your comment, but I want to ask you a question. So you said you start with the rotablation, right? So how do you plan to send your rota wire? Would you like to use first hydrophilic wire with microcatheter and cross the microcatheter and change the wire, or how do you do that?
This is a very practical question. Thank you. In this case, you have large vessels. They are not particularly tortuous, and your tight stenosis is very short. So in this case, your rota wire, of course, it's an odd wire, is unfriendly, but in this case, it will go easily. You go from the left main to the LED, you push it and it will go. I think you will not need to exchange your hydrophilic wire on a microcatheter. The trick you mentioned is a must when you have tortuous vessels, long lesions, small vessels, where the rota wire is very difficult to advance and to control. So you put your favorite wire, you put a microcatheter, remove the hydrophilic, put the rota wire, remove the microcatheter, and this is much easier.
Okay, so I'd like to ask the panel here, is there anyone who start with the balloon dilatation here before try rotablation? Is there anyone? Would you like to try balloon dilatation?
Yes, hi Omar, I'm Dr. Maged Ramses from Egypt. Yes, for me, I think beginning with NEC balloon, and you can have an idea first by IVUS to detect if a balloon only can do the job or you need the rotablator, because the IVUS will tell you how the calcification is and how it is severe. You can go by balloon only, NEC balloons, or rota is a must. Because I know it's calcific, but maybe the calcification in this old age is from only outside, and from inside is not that circumferential calcification that be hard, that is mandatory to use the rotablator. So doing first pre-dilatation with NEC balloon and passing the IVUS wire will direct you if you need to do rota or you can do the job with only NEC balloons. So IVUS is a mandatory first before deciding.
Okay, any comment?
Yes, for me, and I have a question to Flavio. And I think in this acute coronary syndrome, we had some slow flow in the LED. If there is any concerns about using rota and this potential slow flow and acute coronary syndrome?
It's a good point. If you don't oversize your burr and you start with a 125 in this case, and you take your time, I mean, you are not in a hurry to cross, you use your picking movement. I don't think that you have more low flow with rota than with a balloon. It's an acute coronary syndrome, so you might have low flow also with a balloon. The good thing is that once you have gone through the lesion with your rota wire, you know that the procedure will be much easier because the balloon will open the lesion and then your stent will be well expanded. The option of starting with a balloon, it's of course a good option. It's all about doing it as a second choice or as a first choice. And you know what? There is no scientific explanation for that. There is no demonstration. It's a matter of good luck or bad luck. You put your balloon, it opens. You put your stent, it's a great result, and you manage in 10 minutes. This is good luck. In other times, you do all the same, and the lesion remains very, very undilated. You create dissections. Then when it's a big dissection, you will not be comfortable with rotablation. So what Ahmed said, if you think you will need it, use it. Because if you never use it and you use it only when you are in troubles, then rotablation will create more trouble because you don't know how to deal, you are not comfortable, you feel nervous. So the more you use it, the easier it will become. So this is why I do prefer to tell those who are a little bit reluctant, do it once more rather than once less. And each time you will perform better.
Yes, Flavio.
Flavio.
Yeah.
Sorry, Omar, go ahead.
No, go ahead, Ahmed, please.
Dr. Hussein and Dr. Ahmed, now you're very experienced with rotational atherectomy, orbital atherectomy, and lately IVL. So let me sort of, apologies for, I put the slide last minute, so I didn't put the clinical presentation. To complicate matters, the rejection fraction was 30%. And given her extensive peripheral vascular disease, Impella was not available. Unfortunately, I was not at my center. I was visiting, and she presented out of nowhere. And she's not really an ECMO type with her peripheral vascular anatomy. Impella is not there. So the concerns about no reflow were dreadful to my way of thinking, were quite important in this particular age, presentation, anatomy, and ejection fraction. And I totally agree with what Flavio said. There is no science behind it, but what I can tell you for a fact, if you decide to go sort of over optimistically with balloons and start upsizing them, you will get into no reflow, and then you'll be doing your rota in very unstable circumstances. So with this in mind, would anyone consider an alternative? I totally take what Flavio said, a small-sized burr, keep your runs short, take your time, will probably guard against no reflow. But with the poor EF, would you consider something different, Flavio, Omar?
Yeah, Ahmed, to be honest with you, in this view, I see, very tight lesion there. It's almost to me, suboptimal, subtotal occlusion. Yep. Right? There is very tight point, somewhere, very, 99% stenosis. I'm really, doubt if we could send, rotawire directly. I'm not sure. So I think in this case, what I do in my routine practice, mostly because of the cost issue, almost always I try with the balloon. Yes, for example, in this case, I would use a hydrophilic wire to cross the lesion, and then I tried 1.5 balloon first to touch the lesion and to feel how much it's stiff and severe. Then if I could open it, I go 2.5 and trio, and then I implant the stand. Otherwise, if I couldn't inflate 1.5 balloon, then I of course use rotablation here. But first, in my routine practice, mostly because of the cost issue, I try with the balloon.
So that's a 2.0 balloon, and this is the response you got. It was easy sending a run-through wire. However, I do take your point. It looked like a subtotal occlusion with a lot of calcium, and I wasn't sure my rota wire was going to sail smoothly. So we sent in a run-through wire. That went smoothly, a 2.0 balloon, poor response, exchanged over a microcatheter. Started off straight away with a 1.5, essentially because of availability, did a few runs, and we finished with left main LED stenting, just as Flavio said. But my point here, and it wasn't the greatest expansion, we got a minimal stent area of 6.9 with intravascular ultrasound and the ostial LED, which is not great, but given her age and presentation, and in all honesty, my lack of familiarity with the place I was practicing in, I sort of said, let her live for another day. That was like 2 years ago, and she's still doing fine so far. My question to the panelists, especially those of you who are more familiar with IVL, we didn't have it at the time back then. Would this be a case where you would consider for hemodynamic purposes to go with an IVL balloon, obviously after an initial pre-dilatation?
Actually, I agree with the option of primary rotablation, and this is what I tend to call it a primary rotablator. So I agree with your point of view. When you need it, just use it from the beginning. Otherwise, it will invite more problems. A little science behind this is the IVAS images after BUBA and after rotablation. So the main mechanism of balloon, as you all know, is uncontrolled dissection. So you totally uncontrol what you are dilating. But with the rotablation, the smooth surface after the burr that you get with the minimal dissection, I think it encourages you to go primary with the rotablation as a first choice. In terms of speaking about the IVL, this is a very ugly lesion, and the calcification morphology is not clear and will not be able to clarify this with IVAS because of the nature of the lesion itself, the very tight nature of the lesion. So with these ugly lesions, the incidence of calcium spurs and calcific nodules are very high, especially in this age, in this patient age. So I anticipate the presence of these nodules, and the usage of IVL might be hindered with the nodules. We had sometimes with the rupture of the IVL balloon itself in the presence of calcific nodules. So my primary approach would be a primary root ablation, small, very small bear, very gradual upsizing if needed. This is also to avoid the instance of distal embolization. And then after finishing that, you can resume the normal balloon dilatation and stenting.
Thank you.
Great. Thank you, Ahmed.
Thank you so much.
Thank you.
I may have a question for Ahmed and the panelists about if there is any place or an edge for IVL over rotablator in certain scenarios or certain clinical or angiographic situations.
If there is enough lumen and you can deliver the IVL, because it's not a low profile balloon, it's a bulky device. And
Yes,
in many situations you need efforts to deliver it across tortuous or even just a calcific lesion. So you need to make sure that you gain some lumen and then you deliver the IVL. And the best way to gain the lumen to me is either a rota or a CSI orbital atherectomy.
So is this a patient where you would consider after the initial balloon dilatation IVL for safety purposes compared to rota?
I'm not sure about safety because balloons can rupture, as Ahmed said, with calcific nodules. And if the balloon ruptures and there's an abrupt vessel occlusion, then you'll be in deep trouble because the vessel will not be been prepared. You'll not be able to deliver the stent and you're stuck in the middle of nowhere. So always create a small tunnel through the vessel with rota or whatever, and then deliver whichever you want.
So apart from treatment of an underexpanded stent, is there a sort of a clinical or anatomical scenario where there would be overwhelming preference for IVL?
Tortuosity.
That's a good one.
That's the main, because I know Ahmed Khashaba is an expert in rota, and he will show the cases where he can go through a tortuous circumflex. But mortals like me, I wouldn't try it in a tortuous circumflex. If you have a lumen that can deliver with a guide liner with body wires, then go ahead with an IVL if there's tortuosity.
Flavio? Thank you.
Yes, I agree. The IVL has shown efficacy and a very reliable safety. I mean, in the studies that have been already published, there are no cases of perforation, which is very, very rewarding. It's true, if you have a very tight lumen, the balloon will not cross. So for me, very tight lumen, a very small MLD, it's an indication for rota. Like having very long lesions, very long lesions is for rotablator, because then you know this shock wave balloon has 80 pulses. So at a certain point, you have to open another one, and it's an additional cost. And it does not navigate very easily in the distality. So I think that the two devices have quite some overlapping, but some specific indications. It's good to have the two of them. It's of course much easier to use the shock wave because it's just blowing up a balloon. But if you deal with complex lesions and you work in a high volume center, you need to have also a rotational system. I cannot say anything about the orbital atherectomy because it's not available still in Italy and I have no experience. But once you have rota and IVL, you can do practically anything in the corners. I agree. I have been using more and more the IVL, more for curiosity to learn how it works than for the need, because if you have a rotablator, you can do 99% of your cases. And I have to say that it's very appealing because it's easy, it's quick, and we are learning on the intravascular imaging. It's very effective also. So I think it's a device that will gain a lot of market share and easy to use, but will never replace rotablation totally.
I have a question to Flavio, please. From your experience with IVL, is there a relation between the success or usability of the balloon and the extent of the arc of the calcium? So is there any limitation to use the balloon with a specific minimal degree of arc of calcification?
For the cases we have used, I have to say that we have used these cases, especially in asymmetric bulky calcifications, when you know that the rotablation will ablate more the normal part of the wall than the calcium. So this is a good indication. We have these bricks, these rocks, squeezing the vessel on one side. We have been using IVL in this kind of cases. And indeed, it works. You will make at least one fracture. It always creates a fracture, but then you know that your stent will not be round. When you put the stent in any way, you will get a good MLD, but the stent will have a D shape anyway, even if you do the IVL. So it's not that you will get all your stents round, unless, I don't know, you should go for bigger and more aggressive, but you know, vessel wall rupture is always there, and we have to do everything to avoid it. So we will see. Of course, the more people use it, we will start hearing about complications, but so far it seems to be a very safe device.
I think
Omar, sorry.
Yeah. I think IVL and rotablation is two different devices to me. You know, I could use in many places rotablation, but IVL I have some limitation, I believe. Mostly, I like to use IVL if I have proximal, proximal lesion or left main lesion, very calcified lesion. It helps a lot. But if you have something middle of the artery or more distal, it's not easy to insert that bulky balloon in that place. So in those cases, mostly we need rotablation. Okay. Any question, Ahmet, or the other colleague?
Yes, there is a question from the followers about the possibility of using scoring balloon if the rota is not available and the non-compliant balloon did not open.
So I'll leave that to perhaps Hussein Hashmat. You want to add something? I've had sort of a disappointing experience with scoring balloons in particular, and to a lesser extent, cutting balloons. In my lab, we're only using cutting balloons now to treat or as part of treatment for in-stent restenosis. Otherwise, if you have a calcified, this is usually in lieu of a drug-coated balloon or another stent. If you have a lesion where you think you need a dedicated calcium modifying tool, we have rotational atherectomy, which we're very comfortable with, and lately IVL.
Cutting and scoring are useful, but they lose their meaning if the calcium arc is 270 degrees or more. So I wouldn't try if I see the arc 270 degrees or more.
And the other thing is that they are very bulky as well. I mean, you have to have a human starting with in such a lesion that you have presented, the pinpoint lesion, ugly lesion. You still have the problem of crossing that lesion.
Okay, guys, I want to ask a question to Ahmet Kashabar, practical question. Ahmet, if you crossed the wire, but if you couldn't cross the first balloon or microcatheter, what would you do for the next step? You crossed the lesion, but you couldn't cross with the balloon, say 1.5 balloon. What do you do?
So before inflating the balloon, right?
Yes.
Okay, so this is again the rule of primary rotablation. So I just changed the wire, try to manipulate with the rotablation wire. Sometimes it's difficult, but in most of the time it's doable to pass the lesion with a rotablator wire, especially as Hussein mentioned, if there is no, or sorry, Flavio mentioned there is no tortuosities down the stream of the artery. It's manageable to push the primarily the rotablation wire. So
if you don't have the rotablation,
if I don't have an uncrossable lesion. So I try to increase the support, either passive or active support. The first thing I'll use is a guideline extension and try to
you choose first guideline rather than anchoring balloon, right? Is it your choice, or you try first anchoring balloon? First approach.
First, I tried the guideline. It's easier. It's more practical. It's handier. So and less injurious. So it's more controllable. So it's more safer to in my view, it's more safer to use the guideline extension to increase the support.
Another option.
Any other idea? Yes, Shane.
Another option in non-crossable lesion is the blimp balloon. It's from a Dutch company, and it's a short. It's a tiny, very short monorail, and it's usually not for dilating. You go to very high pressures, but it acts like a scoring element beside the wire that tries to modify the plaque somewhere, so that you're able to deliver a CTO balloon like NC Nano or Sapphire balloon, blimp balloon.
The blimp balloon is useful. A threader from Boston Scientific, which is again very similar, it's sort of a microcatheter with a balloon attached to it, is also useful. You can try a lower profile microcatheter. You can try a microcatheter with external braiding, like a turnpike spiral, or even go for a turnpike gold. And this is sort of all the different degrees you can try, dottering, wedging your balloon within the lesion and inflating. And we're lucky to have a number of very low profile. So we've gone down to a Sapphire 0.85 nowadays, and they can occasionally be helpful. And if all that doesn't work and you still don't have your rota on shelf, perhaps I understand, and I don't have any personal experience with orbital atherectomy, but I understand that the Viper orbital atherectomy wire is easier to handle than a rota wire. So that can be another option, going for orbital atherectomy, utilizing the ease of use of the wire with the system. If all of that doesn't work, then you will resort to mostly more aggressive techniques, be it granuloplasty, trying to create a wedge, a 1.2 or a 1.5 balloon, inflate it and rupture it to try and modify the calcium at the entry of the vessel. If that doesn't work, then dissection and re-entry techniques become your almost remaining choice, be it ADR or retrograde reverse cut. So this is an excellent question for Omar and for you. And it's not just CTOs. If you're dealing with heavily calcified subtotal occlusions, it's not a scenario that is exactly uncommon. Now, I think these are excellent questions, but we are, I'm conscious of the time. So we're just in time for Dr. Ahmed Khashaba's talk. And Ahmed Khashaba, besides being a very dear colleague, is extremely experienced with rotational atherectomy. When I started doing rotational atherectomy, I'd just go and stand and see what he's doing. And he's a pioneer indeed in Egypt and the region with the use of complex and advanced techniques from the very beginning. Dr. Ahmed, a pleasure to have you.
Thank you so much, my dear friend Ahmed, for the very nice introduction that I hope to deserve. Actually, I am going to present. I hope all can see my screen.
Yes, sir.
Okay, great. So this is a case of primary rotablation in a patient with multi-vessel disease, namely two-vessel disease. And as we all were discussing in the previous minutes, I named it "Don't hesitate to dare." So when you think that you need it, use it. This is the primary message of the case. This, strange enough, this was a relatively young patient, 52 years old gentleman with a body mass index of 29. His only risk factor, his risk factors are dyslipidemia, smoking, and hypertension. And he presented with effort angina and NIHA class 3 dyspnea with a negative troponin. So this is a chronic coronary syndrome patient. This is his left coronary angiography. As you can see, a significant proximal LAD lesion, circumflex just mild irrigatus with no significant lesions. But if you appreciate with the without even the contrast, you can see the LED full of calcification down the artery, mainly in the mid LED segment. This is his IVUS run. Start just directly if the IVUS can pass the lesions, just to assess as we mentioned. And this is his phased array IVUS down, pull back in the LED. And as you can appreciate, the LED, mid LED part is full of calcification, and which is relatively spiral at different segments. And at some segments, as you can appreciate here, like at 7, 6, and 7 o'clock, there are some calcific nodules as well in the lumen. So this is the pullback continues until we come to the proximal LED lesion, full of calcification, some superficial, some mostly deep calcification in these segments where there is no appreciable lumen narrowing. But coming back to the ostium of the LED, you will appreciate a very tight lesion with a high black burden, but no significant calcification. So based on this IVUS analysis, we plan to go directly with a primary rotablation. And here you can see we pushed another rotablation wire beside the first wire, which was used only for IVUS guidance. And as you can see, this is not the best wire in the world, but you can manage, in absence of tortuosities, you can manage to push to the end of the LED. And starting with a 1.25 bare, just to ablate the mid segment of the LED as shown by the IVUS, which contain most of the calcific nodules and the calcium. And this is after the first run, balloon dilatation, which because after the first run, we thought that we already modified the calcium enough. This is the stenting and post dilatation, and we are done with the mid LED. And because of the absence of calcium in the proximal LED lesion, we opted for stenting in the ostial LED. Although I'm nowadays I'm fan for the crossover technique with the not precise stenting of the LED ostium, but because of this particular patient, the difference between the left main size and the LED size was very big. So at that for this particular lesion, we opted for precise LED ostial stenting, and this is an injection during the balloon inflation, which if you stop and have a look, it shows that the stent is a little bit precisely at the edge of the stent, and what you see hanging in the left main is the hangover of the balloon itself. So this is the final IVUS run of the, the final IVUS run of the LED after stenting, which shows this is the distal LED stent widely opened with good expansion, and this is the intermediate segment, and this is coming back to the proximal LED. This is the proximal LED stent and the left main, and as you can see here, the stent and the proximal LED is more or less precisely adjusted to the ostium of the LED. Now I'll take you to the main problem is the right coronary itself, and as Hussein mentioned, you are faced with some tortuosities, and this is a very tortuous right coronary in the beginning with aggressive amount of calcification in the proximal segment, and particularly at that bend. Again, I tried to push the IVUS, but the IVUS was stuck there. As you can see, the IVUS is not passing, and trying to take the run, you only see the calcific nodule at 7 o'clock, which it was hindering so much the IVUS from passing downstream the right coronary artery. So again, there is no solution except the rotablation at this particular time. And if you can concentrate on the proximal part of the right coronary, you will see the calcium at this the lesser curvature of the RCA, and this is where I adjusted my wire bias for the rotablation to be hitting this particular segment in order to modify the vessel, the calcium at this site of the vessel. Fortunately enough, this worked, and I could pass a stent directly down to the distal lesion in the RCA, which didn't seem angiographically very much calcified. I could not assess this with IVUS because I lost my IVUS probe while trying to pass the proximal segment, and it was not working anymore. So I lost the ability to assess with IVUS at this particular segment. So I stented the distal part, some under expansion in the distal part of the stent. As you can see, this was easily corrected with a post dilatation of the stent. Again, the proximal stent could be passed to the proximal lesion after the rotablation only with a 1.25 BER. And unfortunately, during inflation of the stent, a deep breath from the patient just moved the stent a little bit proximally in the lesion. So we had to stent it with the post-dilated, the first one, and we had to stent it with another stent to just complete the stented segment. Some under expansion at the site of the calcium, as you might appreciate, but this was again dealt with some post-dilatation. This is the final at that particular index procedure, except some, to my eye, some accepted to a little extent, but let's see what happens at 1 year follow-up, because the patient presented again with an effort angina 1 year later, again with a dyspnea, some dyspnea, and a negative troponin, not an acute coronary syndrome fashion. I expected actually the problem to come from the stented segments, from the rotablated segments, but an angiography at the left system showed a good result 1 year later of the stented LED segment with no apparent problems at that site. This is all the left stent. The ostium of the LED looks fine 1 year later, and as well as the mid LED. The RCA was the problem, but not as you could expect from the proximal segment, but from the distal segment down there in this distal RCA stent, which showed a pinpoint, very tight lesion in the distal part of the stent itself. The proximal segment that caused the problem looks fine in most of the views. So this prompted me to just to have a very good look at the distal part of the segment, and angiographically it looked like a stent fracture at the very distal segment of the distal stent. So we just cannulated the LED, we wired the LED, and primarily also because of the presence of the previous calcium and previous stents, I tried to use directly the guideliner extension to make my life easier in delivering further equipment in the right coronary. Some problem in advancing the guideliner itself, as you might appreciate, due to the previous calcifications, stenting, and angulations. So I used the anchoring technique to facilitate delivering the guideliner extension, and at the same time to dilate the lesion. And after succeeding to deliver the guideliner extension, there were no problem to deliver the stent to correct the distal lesion and inflate it and post-dilate it as routinely done. And this is the final picture after correcting the problem in the distal stent 1 year after the index procedure. This is before and after the second procedure. So my take-home message from this case is that primary rotational atherectomy could be a key to success in complex cases of coronary calcification. It's safe, feasible, and makes your life easier. IVUS is an invaluable tool during this complex PCI, and if you go transradial, this is not an obstacle to any complex intervention. Thank you so much for listening.
Thank you so much, Dr. Ahmed. Again, an excellent presentation as always.
Thank you.
Now, I want to ask you a few questions, being one of the rotational atherectomy experts in the region. So do you always use a Judkins right when you're dealing with particularly a tortuous right coronary artery when you're planning to do rotational atherectomy? And does that have It obviously comes at the expense of good support, but does it have an advantage in terms of minimizing wire bias?
Yeah, and in this particular case, I used the right Judkin because of the takeoff of the RCA, the upward origin of the RCA, and it's according to the shape of the takeoff of the RCA. So sometimes I use the right Judkin, sometimes I even use the Lima catheter. It depends on how the right coronary takes over from the aorta. Of course, if a normal takeoff of the right coronary, I prefer the left amplets for good support, but it really depends on how the RCA is originating from the aorta.
Okay. Flavio, you had an excellent series on calcified lesions with PCR online, and that was like 4 or 5 years ago, and I found it extremely useful for beginners and even intermediate operators with rotational atherectomy. How do you balance wire bias? I mean, so classic teaching was trying to avoid double curved guidings. I have to admit that I not infrequently resort to those to improve support in hostile anatomies. But apart from that, what tips do you have for us and for the audience to minimize wire bias? And do you actually check for it?
So, a nice practical point. I think everybody should know, and experts will agree, that the rotablation bar does not require a very high support. I mean, it's much easier to go with the rotablation bar than going with a balloon or going with a stent, which might be impossible. So it's not that you need an amplatz intubated on your right. Once you have put your wire, and you know there are two rota wires, the floppy and the extra support. Of course, in a case with tortuosity, and if you have to rotate the distal part, the extra support will give more support, and sometimes you need it. But you don't need too much support unless the vessel is very tortuous. But be careful, because the more tortuous it is, the higher the risk of having complications with rotation and atherectomy. The first of all, and the most dreadful, is the bar entrapment, because bar entrapment happens for different reasons. The bar might be too large, or the movement is too fast, or you do too much pressure on the bar. But I think that most expert operators know that this happens when the vessel is very tortuous and the lesion is very distal. So in these cases, I think that using an extension catheter is the safest way to do it, because you eliminate all the friction you have in the proximal part, and you exit your rotabar just in front of the lesion you want to ablate. So these are my advices. Of course, in some cases, an amplatz guiding will give you more support than a Judkins, but the concept is that you don't necessarily need to be too aggressive with the guiding when you use rotablator, because it smoothly goes step by step more distal as it ablates and creates its own way to the distal part. The use of extension catheter that were not available 10 years ago has offered much more safety for the rotation of tortuous and distal lesions.
That's an excellent point indeed. And if I may add to that, not placing your wire excessively too distally, if you're already past the lesion, will help minimize that unnecessary wire bias. But the use of a guide liner has indeed made this a safer procedure. Now, one thing for the audience is, while intuitively you would think that larger burrs are more prone to burr entrapment, beware that the smaller burr, in particular the 1.25, because rather than having a spindle shape, it has a cylindrical shape. So the shoulders, the proximal shoulders, can become entrapped, especially if you ablate too quickly, the so-called Kokeshi phenomenon. So this is why Flavio is stressing that you want to take it slowly. You want to ensure that you're ablating smoothly and consistently in the proximal part of the lesion before progressing into the more distal parts of the vessel. Now, speaking of guide liners, Omar, so what are your tips and tricks apart from anchoring to deliver a guide liner or a guide extension through tortuous anatomy. So we've seen Ahmed use an anchor. I'm sure you have a couple of other ideas on how to progress those safely and effectively. Unmute yourself, Omar, please.
Yeah, very good question, Ahmed. Yes, as Ahmed Kashaba showed us, we can anchor the guideliner at the distal and we can push over that anchor balloon, or we can dilate the balloon very, very proximal to just distal to guideliner. And when we deflate it, we can push the guideliner forward, then it will go more. So there are basically two types of sporting guideliner. The first anchoring balloon, like Ahmed Kashaba did, and the secondly, as I told, you can inflate balloon very proximally, just distal to the ostium of the tip of the guideliner, and when you push, when you deflate the balloon. So there are two ways we could do.
So this inchworming is indeed very effective, and you'll be surprised how much you can sort of progress in very hostile anatomies. So one other thing with eccentric or wire bias and eccentric ablation, just as Ahmed shows us, while I was in Japan a few years ago, a very experienced operator, I think Omar definitely knows him, Yoshifumi Kashima, and Flavio might know him, who has like done 2,000 rotational atherectomies. And he was particularly fond of sort of a pendulum-like movement if you go to particularly lower speeds. And this would allow the burr rather to stay on the vertical axis of the wire, to start moving ever so slightly to the sides and give you a sort of orbital atherectomy type of eccentric ablation rather than concentric ablation. Any experience with this? Flavio, have you tried to ablate at a speed of 120 or 130,000, for instance, with this in mind? Flavio, you're muted and you're unhappy.
Yeah, no. I was thinking, because again, there is no science on that. I mean, everybody says one thing and the contrary. It depends on your own experience. I am keen on higher speed. I have the impression that with higher speed you are more effective. But again, it's I normally start with 160, and when the rotational maneuver gets very long, because you don't go through, I even increase the speed to 180, 190. In some cases, the calcium is so tough and the lesion is so long that you don't go through, and you have to consider that the bar, which has these diamond crystals in the tip, may lose its effectiveness. And it happens that you change it for a new one, and finally you need 2 bars to go through. So, but of course, you have been doing this for more than half an hour, and in the end, it becomes, but you never need to be in a hurry. I mean, I don't know. I wouldn't say it's right or wrong to go 120 or 190. What I say is wrong is trying to cross very quickly. That will risk the entrapment, the low flow, the hypotension, chest pain.
Yeah.
Very, very, very slowly, taking your time. It doesn't matter how long it takes, because you are doing cases that may be impossible otherwise. So when you reach a good result, you must be happy. You don't need to look at the watch. I mean, you take your time.
If I may comment
that's
on,
very important. Go ahead, Dr. Ahmed. I just want to stress for the audience that we're not advising 120 or 130, nor 190 to start with, but it's just those extremes where you've been trying to cross and you occasionally have to increase the speed of the burr, 180 or 190, or the very extreme other side, which is a theoretical advantage of having a pendulum-like motion. So, Dr. Ahmed, which brings us to sort of words of wisdom and advice for people with no or limited experience with rotational atherectomy, your sort of 10 golden rules, how to do this in an effective way. Now, we're lucky that the RotaPro is much easier to operate compared to the older device, but people still sort of have a certain degree of fear element.
Yeah, just one word about the low speed and pendulous motion, because I did some benchmark tests on the rotablation, not just inside the patients. So when you go at a lower speed, this does not increase the circumference where the rotablation ablates, okay? Because you are still limited by the axis, the central axis, which is the wire. So this actually does not increase your orbit sort of rotation. Second thing is that the distribution of the ablating elements is different from the orbital atherectomy, because in the rotational atherectomy, it's like a pyramid or a cone, and the touching point to the vessel doesn't have the maximum amount of ablating elements. On the contrary to the orbital atherectomy, which is the burr is mainly at the center point of the rotating element in an eccentric fashion, and this helps you to like side ablate. The orbital atherectomy is a front ablator and a little bit of a side ablator, but the orbital atherectomy is a side ablator. So this is the main different distribution of the ablating element itself. So one thing is that the lower speed will not increase the diameter where you ablate for, because of the centric and central axis of morphology of the burr. And the second thing is that the lower speed will increase let me put it in that word, will not decrease the size of the particles coming out of the ablation procedure. So you are more prone to distal embolizations and microcirculatory obstructions. These are the two things. The higher the speed facilitates the passage, but on the expense of heat trauma, because the higher the speed you gain, the higher the heat trauma, and the influence on the long-term outcome is not very favorable in this regard. So according to the European consensus that was released, starting to ablate between 140 to 160 in most of the cases will do the job without jeopardizing your either immediate or long-term. The second thing is that the very gradual upgrade. If you start, even if you think that it's easier to go with a 1.75 or 1.5, if you start with 1.25, you will decrease the complications, decrease the distal embolization and the burr entrapment, as Flavio mentioned.
So one thing with the practical setup of the lab, are you comfortable rotablating in a patient with a systolic blood pressure of 95? And if that is the case, do you get the blood pressure up before rotational atherectomy?
It's doable, but not very comfortable. I'll not be very happy to start him that way, but I'll not push the blood pressure up. I'll just start with the maneuvers that I've mentioned. I'll start with a minimal burr size, 1.25, the minimal rotational cycles that I'll need. And you reassess in between the cycles to see how the patient is feeling, what is their flow, what is the symptoms, and if you find that the patient is compromising for any reason, you can modify your strategy and try to think something else. And the same applies, by the way, to in my strategy for the temporary pacemaker wire as well.
Absolutely. Dr. Hussein, blood pressure, and in patients with a borderline blood pressure, how short do you keep your lungs?
How short? You never, never more than 30 seconds per run, definitely. And I do a check angiogram to make sure that we don't have no flow, we don't have abrupt vessel occlusion.
Flavio, so
I had a question.
yes. Go ahead, please.
What's the compatibility of the guide catheter extensions with the rota burrs? I mean, can the 6 French guideliner take a 1.5, or do we need a 7 French guideliner? What's the compatibility?
That's a very good point. With the 6, you can use both the 125 and the 1.5. And I don't know if you agree. I am absolutely certain that with the 6 you can go with the 125. I am almost sure you can also go with the 1.5. Like for the guiding catheters, you can be absolutely confident with the 6 French guiding if it is a Medtronic guiding, you will go very easily with the 1.75.
Yes.
Okay. When you use a Cordis guiding or a Boston, the lumen is a little bit smaller, so you will not manage with the 1.75. So I do personally 90% of my rota cases with the Medtronic 6 French guiding, up to 175, but it's very, very unusual that you need a bar bigger than 1.75, because if your MLD is so large that you need a 2-millimeter bar, my advice, use an IVL catheter. You do lithotripsy, it will be very easy and fast and less risky.
It's amazing how that 0.02 inch makes a huge difference, going from
That's a very good
0.71
point.
to 0.69 can make your life very difficult with a 1.5 bar. So my preference is a launcher guide catheter always. I'm not sure with the 6 French guide liner, it will be extremely sticky. So whenever I opt for a guide liner, I just stick in a 7 French guide liner, which brings us to a second sort of controversy, although that is against the manufacturer's recommendation. Does anyone Dynaglide in?
Yes.
Yeah, of course. Yeah.
Routinely.
Routine.
In and out. So, and it's more important to Dynaglide out more than Dynaglide in, because when you push in, you're still in a fresh, especially with a newer burr, and still in a fresh environment without any more blood sticking over the burr, and you can just push. But when you take it out, this is where you need the Dynaglide in most of the cases.
So that's again something from the experts, which is not exactly the standard way of doing it. We Dynaglide out, that's the recommendation, but Dynagliding in is both safe and makes your life substantially easier, I have to admit.
Especially with the dual angulation guiding catheters, but with a single angulation, you don't need it in many of the circumstances.
Absolutely. With this, I think if there are no burning questions, we are just in time for any questions from the panel.
Yes, thank you, Professor Khashaba, for this case. And I want to ask about, as I remember, the IVUS catheter didn't pass in the right coronary.
Yeah.
And I'm asking about the safety of using even 1.25 burr in cases that the IVUS catheter didn't pass. What about the safety? And this is a call for using guideliner or something like that to avoid any problems with your burr.
Actually, the IVUS didn't pass because it showed the reason why it didn't pass. It showed a calcified nodule, or the beginning of the calcified nodule in the proximal RCA, in addition to the angle itself. So if I couldn't see that, I might think of something else, changing the IVUS catheter to another revolutionary catheter or a mechanical with a sheath overwise to facilitate passing, although sometimes this also doesn't pass and break the lens itself. But otherwise, you already knew the reason why the IVUS is not passing, and the only solution in the currently available techniques for the calcific nodules protruding into the lumen to the degree that is enough to hinder the passage of any further equipment is to ablate this calcific nodule.
Thank you, Dr. Ahmed. Thank you, Bassem. So the last case presentation for the day is my dear colleague, Dr. Hussein Heshmat, an astute clinician and one of the most talented chip operators in the region, whom we've been very unfortunate not to have in Egypt for the past few years. But anyway, we're making use of technology to bring him on board. Dr. Hussein.
Thank you, Dr. Ahmed, for the kind invitation, being here with the experts. I guess you can see my slides.
Yes.
It's just one presentation and one case, one patient, and it has many lessons. I'll go through the case and I'll put some stops where I think we can open the room for discussion if you want, or I can continue straight forward till the end. I'll leave that to you.
I think the pause would be great if you don't mind, to keep everyone engaged.
Sure. She's a 90-year-old lady, 90,
but she's reasonably active. She could do her household activities. She could attend the family gatherings. She has diabetes, hypertension, a reasonable glomerular filtration rate. She first presented in December, where she had an ACS, and she had PCI in another city. And we called the doctor who did the procedure when she came 2 months later. And he said that she had a severe lesion in the circumflex, and she had a moderate lesion in the LAD, and there was calcium, and he didn't cross with the IVUS catheter. So he did what he thought of as the critical lesion, and then she was sent home, and she came back 2 months later with a troponin that is 20 times the upper fold of normal. The ECG doesn't locate any specific territory, the same as for the echo, which is reasonable, an ejection fraction of 55, an LDL of 4, and a decent hemoglobin. So that's the angiogram. You can see that there is probably, yes, there's definitely a stent in the circumflex, and there is a metal pipe from the left main to the LAD, and the distal LAD is fine. And there is here what the previous colleague noted to as a moderate lesion in the proximal LAD. And here's the cranial projection. The distal LAD is fine. You see the pipe-like metallic LAD, proximal and mid segments. And you can see a small white dense shadow in the circumflex, probably also a calcific nodule. And this is the spider projection. You can see the moderate lesion, if we call it moderate, in the proximal LAD. And the RCA also has lots of calcium, and it has 2 lesions, one in the proximal and one in the distal segment. This is her second presentation with non-ST ACS. And what should we do next? Is it the LAD, the RCA, imaging, physiologic assessment? What imaging?
Perhaps we stop at this stage. An excellent and challenging case. Not too bad vessels for a 90-year-old in our region in particular. But let's start with Flavio. Flavio, would you go for physiology or imaging?
The question is, the patient has angina?
Yes.
Present with a non-STEMI.
Non-STEMI, yes.
Non-STEMI. So if it's a non-STEMI, physiology is not the most appropriate. I mean, in acute coronary syndromes, you should be able to identify which is the culprit first. I would agree with using physiology after you have fixed the culprit. And the culprit normally has some correlation with the ACG or with the echo. And so if you give us some information on the territory that was ischemic on the ACG or on the echo, we might find the culprit and address this before.
The ECG was non-suggestive?
Okay.
Anything suggestive from the echo?
I think
there were no motion abnormalities in the echo.
Yeah, I think in non-STEMI, it's almost always the ECG and the clinical data didn't point out to the culprit in many circumstances. And angiographically, in this patient, I may vote to tackling the right coronary as angiographically without the aid of intravascular imaging or physiological assessment. Looks angiographically the right culprit.
And then the LAD is not critical.
LAD needs assessment. LAD without the aid of physiological or imaging techniques, angiographically, I may be comfortable as describing it as a moderate lesion, yes.
So Flavio?
Yeah, that makes a lot of sense. With the lack of ACG or echo suggestions of the culprit, then the tightest lesion is supposed to be the guilty. And then you fix that. And of course, prognostically, the LAD is the most important. So there you can rely on the decision guided by physiology. We know that if the ACS was caused by the right, the physiology you will obtain on the left is much reliable. It may change from the acute to a couple of months later, But you know, if it's clearly negative, will remains negative, and if it's clearly positive, remains positive. You should recontrol the patient if you get borderline 80, 81, 82, then it may change. But I think it's a good strategy to start with the right and interrogate physiologically the left.
Omar, any different approach?
No, I agree with Flavio and Asim. Yes, I would do first RCA in this patient, and for LAD, I need to do physiological investigation like FFR.
Okay, I think there is a consensus on that. Dr. Hussein.
We actually went against the consensus because there is a dogma. There's a dogma here. Whenever you see visible calcium on X-ray and the imaging catheter doesn't cross, then this is a tight lesion. Anyhow, we managed to cross with an IVUS, and I'm not sure if you can see the minimal lumen area. The minimal lumen are from proximal to distal. So here's the aorta, and you can see the longitudinal below. So here's the left main. You can see the calcium from 3 o'clock to 9 o'clock. And here is the ostium of the circumflex at 1 o'clock. And then you can see how negatively modeled the LAD is. And you can see that here, it's barely taking the IVUS catheter. And here it's even worse. So, and you can see, so it's a metal tube with a long segment of calcium. And in many parts, the lumen area was 2 millimeters.
Yep.
So we were planning to do the same for the RCA, but once we saw that in the LAD, we said it's the LAD. So tackling this LAD, another stop point here. It's a long lesion, and there's many areas with 360 degrees calcium, some superficial, some deep. So what would be the best approach? NC balloons, OPN, debulking with rota, debulking with orbital, IVL, cutting balloons.
Dr. Ahmed Khashaba.
Actually, I just have a question. I cannot see the stent struts in the run or in the cut sections. Is this a new calcification inside the stent itself, or
there's no stent in the LAD. The stent was in the proximal circumflex.
Oh, okay. So because you mentioned a tube, a metallic tube from the ostium from the left main to the LAD, so you meant at that time the calcium.
Yeah.
Yes.
Yeah, he meant the calcium.
So, okay. So with this configuration of 360 degrees of calcification, I would go for definitely in such a LAD, I'll go for the IVL. Despite the fact that the lesion is long, but the circumferentiality of the calcium and the arc, the extension of the arc, will need very good preparation and plaque modification. And I think the optimum technology here would be the IVL. Even if you had to use 2 balloons, each one will give you a different caliber and 8 cycles of 10 pulses each. This would be a reasonable option in such a lead.
Omar?
Yes, I think IVL is definitely the good and perfect option for this patient. But before IVL, I try with NC balloon to test, the calcification. I would do NC balloon first.
See how the vessel behaves. Flavio, any particular preference? I mean, I would use whatever I have on the shelf from the outset, be it an IVL or a rotational atherectomy. But Flavio, any particular preference?
I agree. I think IVL would make it easier after a balloon, because I'm not sure it will cross easily, because you need at least a 3.3035. So probably a 2.5 non-compliant before, or I would also try a rotablation bar would be okay. It's quite a long lesion, so it's a good indication.
Yes,
Okay.
we did what Dr. Flavio suggested, because it's a long lesion and one IVL wouldn't be enough. And we don't have a full stock of full diameters and length of IVL. So we had to pave the way, and we did that with a rota with a 1.5 millimeter burr. And we did it until we didn't have any deceleration across the lesion. And the patient is hemodynamically okay. So we ablated with a 1.5 millimeter burr, 3 runs, each run 30 seconds, and we don't have deceleration. And here comes the question, what's the end point of rota? That there's no deceleration with lesion crossing. We see cracking of calcium by imaging, or we're able to deliver a one-to-one balloon, or we're able to expand a one-to-one balloon. What would be the next most appropriate step after doing a rota?
All of the above.
So my endpoint would be 2 and 4 usually. With aggressive patterns of calcification, I want to see that I actually made a difference with intravascular imaging. So seeing a few cracks across those, particularly continuous circumferential sheets, gives some sort of reassurance, and to expand the 1.1 balloon at reasonable pressure. So I usually go with the non-compliant and refrain from taking it up to 14 or 16. I hardly go above that. If I'm still unable to achieve good expansion, I upgrade the burr size.
Okay,
You know,
excuse me,
Hussein,
Yes.
sorry, I have attended so many meetings and discussions, and it's the first time I see these 4 options as an endpoint for rota. So I congratulate, because it's the first time I see something new, and it's very smart. I have to say that if I could choose one of these, I'd like the 4th. If I put a one-to-one balloon and it opens okay, it means that the stent will open and will be well deployed. I like this.
It's copyright free if you want to take it. So the more practical actually is, as Dr. Flavio said, it's number 4, because you will save time. You will not have to go with the imaging with the IVUS probe and do a pullback and then interpret the image and look for the crack. So the real test would be an NC balloon, and the NC balloon here, we didn't take a one-to-one. It expanded distally, but you see proximally there's still dog boning.
Yep.
So after rota 1.5, there's still dog boning of the balloon. So you definitely need something. So we didn't the rota. We went with an IVL balloon, 30 by 20. You can see my screen, right?
Yes.
Okay, so this is it seems reasonably expanded at 4 and 6 atmospheres in the distal lesion. And we did it again in the proximal part of the lesion, seems to be well expanded. And we said, oh, let's also do the ostium. We went at 4 to 6 and it ruptured. And this is not an uncommon event. Whenever you go to 6 atmospheres, I've seen it a few times that it tends to rupture at 6 atmospheres. But if the balloon is well prepared and there is no air inside, the chances of vessel injury are extremely low. And this is what happened. We just did a control angiogram to make sure that no serious harm has been induced by the balloon. So this is the result after 1.5 burr, an NC balloon, and an IVL balloon. We said we're ready to stent. So we delivered a 275 distally and a 3.5 proximally. And then we did the pot with 4.0. We exchanged the wires in preparation for kissing at the left main, trying to make sure that the wire doesn't go underneath the struts of the left main. And we did the kissing with 3.0 and 2.5. And we can see here with the stent enhancement that we still have some indentation with the calcific probably, we're not sure it's a nodule or just a circumferential calcium not completely cracked. And so we said, let's go for an IVUS. Now we did the kissing, and let's go again from proximal to distal. And here's the aorta, the left main. The stent is well expanded and opposed in the left main. The circumflex ostium is here at 1 o'clock. And we still have some areas of under expansion. The area here, I'm not sure if you can see it or not, the area is less than 5. It's 4.2 millimeters squared. So what to do then?
It's not surprising, Hussein, because I think I would do 3.5 and balloon dilatation before inserting the stent to make sure it's fully open. 3.0 would not be enough in this patient, because this patient has calcification like a tube. So we have to make sure we really correct the calcium. I think now what we can do, I think we can do more aggressive dilatation like 3.5 even for all. If you show us the ostium of the left LAD, we can see the size of the LAD as well, and maybe we can go more aggressive. Yes, for example here, yes.
It's 1, 2, 3.
No, it's
the vertical and maybe 3.25.
Maybe 3.5 at least. To me, 1, 2, 3. Yeah, to me, almost 4 here.
I'll do the same as Omar just mentioned, and if this achieved the required MSA, this would be great. Otherwise, you can still repeat the IVL within the stent with a larger IVL shockwave balloon.
Do you use an IVL in a stent that was just implanted now, or any concerns about the integrity of the polymer and the struts?
No science behind this, as Flavio says, so we don't know, but it shouldn't make a problem. Nobody knows, but leaving a stent underexpanded if you have no other solution would again carry an unfavorable long term to the patient.
Yeah, I will make 2 comments. The first one is that the company says this is totally off-label and you shouldn't. Okay, because they protect themselves and their product, and they don't want to hear that a stent had problems. But talking to expert colleagues, we are all doing that. And I have done this several times, because even after ROTA, even after IVL, in these rocky calcifications, you have this asymmetric expansion, and sometimes the final lumen is not good enough. You put your IVL, you improve it further. Second comment is all the concern about the polymer. And I think this is science fiction. I mean, one of the good
You can use foul language, Flavio. No one will hold it. You can use foul language. No one will hold it against you.
There is a bad thing with calcium. It's difficult to treat. But there is a good thing, that it's very stable atherosclerosis. Restenosis of these monster calcifications with long stents is really very, very infrequent. I have been controlling at long-term patients because you are worried because of the calcium and the long stent, and then you control these patients after 1 year and it's totally stable. You never see restenosis. The problem was at the time of bare metal stents, we were doing the same effort because it was the same rotablation, we had the same stent platforms, but then you have diffuse restenosis. That was really a problem. But with the new generation drug-eluting stents, you hardly see restenosis. What you can have, and is dreadful, is the stent thrombosis. So, in my opinion, if I have not a very, because you have well prepared the vessel, but if you can further improve, use your IVL. You don't care about the polymer and you will not have restenosis. This is my experience. Huh?
So that's an excellent comment. I mean, particularly, both comments, but particularly the first, despite being an off-label use so far, to my way of thinking, it is actually one of the best areas for IVL. at the moment because essentially we don't have any other good options. So it's a breath of fresh air. Dr.
There
Hussein,
might be,
yeah,
there might be another option, going up to a higher pressure.
yes. So I totally agree with Omar. Yeah, I mean, if that fails too.
So we went with an OPN balloon. It's one of my favorite gadgets. We go up to 30, and sometimes 40. And when we try to go 1-to-1.
It's based on experience, but old ladies, 40 atmospheres, sometimes coronaries explode. And when they explode, I mean, you say, why shouldn't I let it as it was? You know, the perfections is the enemy of good, always. I mean,
that's why we didn't take a 3.5.
Yeah.
We took only a 3.0 and we didn't go to 40. We went just to 30 atmospheres. And we ended up with a better result. Now the minimal lumen area is more than 6. And we decided to stop after ROTA, IVL, high pressure balloon, the minimal lumen area more than 6. We said that's fine for us. And the patient was fine and we discharged her home 2 days later.
More importantly
for
her. Yeah.
And this is the final result here, the angiographic final result. So, and we're, yes?
If you want to do better than this, you have to put a mammary artery.
Yes. And we're always minded about how much radiation and how much contrast. So we did IVUS to minimize the contrast with less than 1 gray of radiation. So to me, the take-home message is not only that X-ray underestimates the extent of calcium. Whenever there's calcification, there's a tendency to underestimate the lesion severity. And my own personal dogma, it's not mandatory for anyone. If the imaging catheter doesn't cross and you see calcium on fluoroscopy, then go for debulking, not for ballooning. And one tool alone for calcium will never be enough. You need 2 tools and sometimes 3 gadgets to beat the calcification. Thank you so much.
Excellent presentation, excellent case, and
Thank you very much.
Again, excellent show of how the different tools available nowadays are complementary indeed. So we've seen a rotatripsy in that sequence and with the use of an OPN balloon. For the audience, Flavio's comment, especially with elderly ladies, we've all run into that sort of disaster where you get an explosion-like perforation where the vessel actually ruptures rather than perforates. And it's important to understand that the atmospheric pressure we use is immense. So with your car tire, the inflation pressure is 3 atmospheres. So going to 30 is 10 times as much as what you get in your regular vehicle tires.
The IVL gets 50. The brochure of the IVL is 50
so
atmospheres.
IVL is that radiation wave, that vacuolization and air bubble, it goes up to 50. It hits the calcium, but again, because it's a micro bubble, the overall effect on vessel architecture is very safe. But this is excellent demonstration of how the different tools available nowadays can be used to optimize results. We've seen how imaging is extremely valuable and important. And again, it gave Dr. Hussein some sort of reassurance that again, going 3.0 balloon at 30 atmosphere is something he can get away with, but not particularly easy to do when you don't have full understanding of what the actual vessel size is. So Flavio and Omar and the panel, any final comments?
Yes,
perhaps on this case, the topic as a whole.
Yes, I had
Dr. Bassem, sorry.
Yeah, I had a question for Omar and a question to Hussein. First for Omar, after you see the IVUS imaging of the artery, your suggestion was somewhat strange for me in you are going to predilate. And I think if you don't have an IVUS imaging, I may think of predilatation. But after having this IVUS data with 360 arc of calcification, it's better, yeah, for me, trying pre-dilatation is something maybe hazardous without preparing this calcium. This is my question for Omar.
All right. So you mean we shouldn't touch this vessel without rota? You mean?
Yeah, yes.
No, I don't agree with you, because in my practice, in my country, we do rota, but not that often because of the mostly cost issues.
Yeah.
Yes. So we have great experience those cases without rota. So we do NC balloon dilatation, according to IVUS, because it's very important to size the vessel. And in this patient, if you see the IVUS, if you see the IVUS, lumen size is lumen is around 3.5, even 4 at the ostium of the LAD. So in this scenario, I would definitely go better predilatation to have better stent expansion. Even you do what we see here after rota. After rota, it's not enough to crack the calcium, because the IC balloon was underexpanded again. Because sometimes it happens, although we do rotablation, we need to do OP-NC balloon, for example, if you don't have a IVL. So in my routine practice, I do predilate this patient routinely. I can't use, I don't know, I'm surprised a bit, because it seems to me you do rotablation in all calcified lesion, which is not possible in my country because of basically cost issues. We don't have that opportunity, unfortunately. I think I'm the one of the most rota user in my country, I think, but my number is around 20, 25 in a year. So, but we do lots of complex and calcified lesion without rota. So that's my experience.
Appreciated. We have the same situation here in Egypt. Another question for Hussein about Professor Hussein. There is an extremely important financial issue regarding, you asked an elegantly about the optimal response to the rota, and you put the 4 options, and your decision regarding after dilatation that you didn't open well the NC balloon 2.5, so you go for IVL. What about the finance? If you don't have a good response with rota, to repeat rota again before going to IVL? What about that? To as a cost-saving strategy, to repeat the rota, you didn't reach your goal from rota, and still the balloon is not fully opened, so you go for to repeat rota rather than going for augmenting the cost with adding IVL to rota.
I don't mind going or repeating rota, but I think you're talking about upgrading the rota instead of using the repeat, 1 point.
Okay, repeat with the same burr, or going to a larger burr.
A larger burr has a separate cost, and the cost of the burr is slightly less than the cost of an IVL, but not much less than the cost of an IVL balloon. If I'm minded by cost, then I would go for an OPN. It's cheaper, and I like it personally.
Or what about the option of repeating ablation with the same burr? It adds or will give the same result?
If we go through the lesion and you see that the speed didn't go down, it means that you created a lumen that is almost equal to the diameter of the burr. It means that the speed is, so the burr has give you its diameter. It will not give you an extra diameter. If you need an extra diameter, then you need an extra size burr.
Yeah. So if you go to your elegant, as Flavio said, your elegant MCQ,
endpoints.
So having endpoints, yes. So absence of deceleration makes the burr did his job.
Yes.
Okay.
For that,
can I have a comment or a question, please?
Sorry, yes, one practical point to continue on that question. If you are going to depend on the balloon, I think you have to take an image in 2 perpendicular views, because imaging the balloon expansion in one view still might be in sometimes very deceiving as the angio itself, because it's still a shadow image. So if you are totally dependent on the balloon itself, my practice is just to view it in two perpendicular views, to avoid this eccentric, bulky calcium indenting the balloon from in one view and sparing it in the other view.
Okay. Congratulations, Dr. Hussein, for this illustrative
Thank
case.
you, Dr. Magid. Thank you.
Just a little comment. It's away from managing this very difficult calcification. It's about managing the bifurcation of the left circumflex that has already all the stent. I'm worried about putting another balloon while doing the kissing in the healed stent that already has healed endothelium, that may aggravate the restenosis later on in the ostial of the left circumflex. So do you see it's mandatory also to do this bifurcation, to do this kissing balloon, that you may injure the already healed endothelium in the old stent in the ostial left circumflex?
Your point is very valid, Dr. Magid. This stent was not in the ostium. We saw it on IVUS. There was nothing in the ostium of the circumflex. It was in the proximal circumflex. But your point is valid. Our kissing balloon was a bit longer than necessary. We better did it with a shorter balloon. You're right about that. But as for the concept of kissing in general, it's for the future, because you may need access to this circumflex sometime down the line. You never know. So you need to make sure that the struts of the stent are open in a way so that when you need to access this vessel in the future, you can do it.
Okay, thank you. Thank you.
So any other comments from, thank you. Any other comments from Flavio, Omar?
No, it was great discussion. Very good case, Hussein.
Thank you, Dr.
Yeah, very good case. Very complex case.
So
I
that
think,
was an excellent case. Sorry, Omar, go ahead.
No, go ahead. I think we can close the session. It's now 10 o'clock in Cairo. I think we finished up our time. I'd like to thank all attendees, all panelists, and especially Flavio and Ahmed Gundi. Ahmed, is this the latest wave, right? We have?
Yeah, this is the last wave indeed, and I have to thank you and Flavio for all your input and for putting the program together and bringing life to the program. I think all 6 waves have been extremely rewarding. I personally enjoyed and learned a lot from them. I hope this experience is shared by the audience as well. So thank you very much. Thank you, Dr. Ahmed, Dr. Hussein, Dr. Bassem, Dr. Magid. The points and the discussions raised today were indeed extremely useful. Flavio will leave the last word to you.
Oh, no, I don't want to give the last word. I just I just think talking loudly that this is what is the new life. I mean, I think it's good to be in contact. It's good to see you even through a screen, and to keep on sharing our experience. Of course, those who speak, we are always the same, but I want to think that behind these screens, when you see there are 40, 60, 80, 100 participants, this might be useful for our younger colleagues. Yeah, this is the reason why we are here. And I want to congratulate Ahmed, Omer, and all the panelists, and Medtronic, who has supported this initiative to keep on alive what has been our way of thinking and working. I mean, we are so different to other specialists. We show our cases. We try to learn from the mistakes. We tell our tips and tricks. We say our experience. We are very open and candid. This is a specific brand of interventional cardiologists. We don't keep secrets. I mean, we are not magicians. We are not kings of the surgery. We are very open because we have so many patients and we have to treat them. And their life depends on a good intervention and sometimes on a bad intervention. So it's a model to keep on sharing our experience with our colleagues. And it's my sincere wish that this might be helpful for our patients to benefit from better care from our colleagues who can learn from what we know already. That's it.
It's great last word, Flavio. Thank you very much.
Thank you.
Yeah.
And hope to see
Flavio,
you in
everyone.
person.
Thank you.
In
Thank you
person,
very much.
hopefully soon. Thank you, everyone. Thank you so much.
Thank you so much.
And thank you,
Our pleasure.
Electronic, for the program. Okay, good night, everyone. Bye-bye.
Good night. Good night.